Thanks very much, Gary, for that tremendous overview of those ACG guidelines. And as Gary said, these are publicly available, accessible in full text for your review. What I want to do now is to emphasize some of the points that Gary has introduced. You're going to see some familiar data, and we're going to try to dig a little bit deeper into some of the data that goes behind the recommendations. I first got interested in the idea of preventive care, vaccine preventable illnesses, when I was a fellow in Los Angeles at Cedars-Sinai, which is in Beverly Hills, and I thought that this is a Beverly Hills problem, that we eat granola for breakfast and we don't vaccinate our kids. But in fact, what we've seen and what we've learned is that this is really a problem that's ubiquitous, not just in Southern California, but throughout the country, throughout North America, and throughout the world. There's a survey that was done in Canada of 167 patients with IBD, and importantly, their GI doctors in a geographically confined area. So you had the patients and their doctors and could link one to the other. And this survey basically was to understand what are the attitudes, knowledge, and beliefs that patients and providers have around vaccine issues. Patients, understandably, were the most confident of all of their various providers that their gastroenterologists were giving them the accurate information about vaccinations. But when they asked their gastroenterologist, meaning the same doctor of the patients who had the most confidence in their GI docs, only 14% of the gastroenterologists reported actually getting an immunization history from their patients. 43% didn't know which vaccines should be avoided in immunosuppressed patients, and none of them thought that they actually knew enough about immunizations in general to be able to convey confident recommendations to their patients. So clearly a knowledge gap that translates potentially to a care gap. This was the survey that was done in ACG, so this was a US-based survey, basically found similar findings that many gastroenterologists, when presented with scenarios, would you vaccinate this patient, for example, with a live virus vaccine, would incorrectly say yes in patients who are immunosuppressed. Significant knowledge gaps were addressed, but what also came out from there was the gastroenterologist as a whole felt that really it's not my responsibility, it's the responsibility of the primary care provider. And so whose responsibility is it? One can argue and debate, but I think that those of us that are prescribing these medications should at least be able to convey to our patients what the risks are that surround the medications that we're prescribing, as well as mitigation strategies to how we can potentially prevent preventable complications. They can then take that information to their primary doctors. We can communicate it to their primary doctors, or as in some of us on the panel, and we can talk about this, we may have strategies that we've decided to take upon ourselves as gastroenterologists who care for patients with IBD to be able to administer those vaccinations in our own clinics. This is the study that Gary alluded to earlier that we did at Cedars, showing that patients who were at risk were not getting the vaccines that they were indicated to have received. But the important nugget that I think is really critical to point out with this study that we did is that the vast majority of patients actually had a primary care provider visit within the prior 12 months. So speaking to the point of whose responsibility is it, they're seeing their primary care providers, that's not the issue, but they're still not getting their vaccinations, so something's falling through the cracks, and what we can do is what we can do, which is to educate ourselves, educate our patients, and educate our primary care colleagues. So Gary's highlighted the recommendations that are in the ACG guidelines. Just to emphasize a couple of points, vaccination against influenza annually and pneumococcal vaccination with both vaccines, as Gary mentioned, and I'll talk a little bit more detail about them, the conjugated PCV13 and the polysaccharide PSV23 in those that are immunosuppressed. And I think I want to highlight these as respiratory infections which are potentially preventable. These are public health hazards. Obviously, the flu season every year, there's a major public health initiative globally that we are part of, and we need to think of with specific reference to our patients who are immunosuppressed. These vaccines can be given together. One doesn't need to worry about giving two vaccines in the same patient in the same day. It's not going to trigger an immune response. There have been many studies that have demonstrated that in IBD. We'll talk a little bit more about the zoster recommendations. Gary mentioned hepatitis B and the HPV vaccination as well, which, again, to emphasize, is for women and for men up to age 26. In addition, there are vaccination considerations that may be special cases that relate to patients' occupation or travel. This is a study demonstrating that we know that these infections are at higher risk. And actually at DDW, there have already been, there was at least one presentation that I attended demonstrating increased risks of hospitalization for many of these infections that are vaccine preventable. So here is a study that Andrew Tinsley did looking at the market scan Truven database, looking at the risk of influenza, showing that it's higher in IBD compared to control populations, but importantly, to emphasize the point that it's not just influenza, it's the complications that result from influenza. One common one is pneumonia, and certainly being hospitalized as a result of this respiratory infection, again, also increased in patients with IBD relative to non-IBD controls. So getting the infection more common, and then getting a complication for the infection among those that get infected, also more common. So who should get vaccinated? Again, to remind everybody that over the age of 6 months, everybody's intended to get vaccinated and should be targeted in public health campaigns, but with specific reference to our patients who have increased risk of immunosuppression. The cartoon there is just to remind us that there were days, I'm sure we can all remember, when it was really difficult to get a flu shot because there was limited stock, and people might make some back alley trades to get a flu shot. I heard that geographically this may have been the case, or may still be the case, with the new recombinant zoster vaccine. I guess we'll see when we start to prescribe it how readily available it is. When it comes to when should the influenza vaccine be given, the question that's posed in this symposium is, does timing matter? And timing probably doesn't matter. When you have the patient in front of you, that's the right time to vaccinate them against influenza. Wherever they are in their infliximab cycle, that's the right time to target them for influenza if they're there in front of you and you have the opportunity to do so. Not to worry, there have been multiple studies that have demonstrated that influenza vaccination does not impact IBD disease activity, and the greatest risk that one might have from the influenza vaccine isn't so much a safety consideration, it's that the vaccine may not be as effective as it might otherwise have been had patients not been immunosuppressed, but that's not a reason not to vaccinate them. One talk that was at DDW, I think it was this morning, yeah, so looking at high-dose influenza vaccination. There's an influenza vaccine which packs 4 punches for the price of 1, and so the talk this morning was on looking at the effects of this super influenza vaccine on patients who are on TNF monotherapy, showing that significantly improves response rates. I think we still need to study this and other ways of achieving greater rates of efficacy in patients who are getting vaccinated, but certainly reassuring that we have vaccines out there that are being used for other populations, like the elderly, or like other immune-suppressed conditions that we can extrapolate to IBD and use these vaccines for our patients. Just to harken back, it was 100 years ago now that the worldwide devastating flu epidemic occurred, where tens of millions of people died, and to remind us that influenza is frequently complicated by pneumonia. So when you give somebody a flu shot, you're not just preventing influenza, you're preventing the complications of influenza, including pneumonia. And to remind us also that public health campaigns have been around for a very long time. So if you're sick, if you're coming down with the flu, as it says in the bulletin on the left, go home and go to bed until you are well. Don't go to work and expose your coworkers so that they can expose everyone at home and transmit these infections. Reminding us back in the days, even the church is closed to stop the spread of influenza. Pneumonia risk, as Gary showed us from Millie's data, and I just want to dig a little bit deeper into Millie's data, and maybe we can talk about it, Millie, is that not just is the risk of pneumonia increased in patients with IBD, but it's specifically associated with certain kinds of medications. And if we look at the list, which ones might we think are the most important to be thinking about, wouldn't necessarily have picked these two, but corticosteroids and narcotics are the 2 classes of medications that seem to be most greatly associated with increased pneumonia risk in our patients with inflammatory bowel disease. It's not the patients on biologics. Again, it's the patients on corticosteroids and narcotics. And so our patients with narcotics, another theme that actually has been permeated through this DDW is the rising incidence of the use of narcotics and the persistence of the use of narcotics in patients with IBD, linking this now to infections and linking to pneumonia, and recognizing that these are our patients who need attention. So I alluded to the question of a blunted vaccine response in patients who are immunosuppressed. And a question that comes up often is, well, which is the offending agent when patients are, for example, on combination therapy with an anti-TNF and a thiopurine or an anti-TNF and methotrexate? So this was a meta-analysis that we did to look through the literature and understand what is the influence of monotherapy with an anti-TNF versus combination therapy. And basically throughout the literature, in both the GI literature and the rheumatologic literature, there does not seem to be a significant impact from anti-TNF monotherapy. It's really when the monotherapy, the anti-TNF biologic is combined with a thiopurine. And actually studies that have looked at thiopurines or methotrexate alone have shown a blunted response in those patients, almost as bad as patients who are on combo therapy. So the offending agent may not be the biologic drug. It may be the thiopurine or methotrexate, which are significantly blunting the ability to mount an appropriate immune response to vaccines. And that's something to remember. We think about the biologics as our patients who are at risk, but remember that thiopurines and methotrexate are probably the biggest actors when it comes to blunting those vaccine responses. And this was a study that we did in our center looking at pneumococcal vaccine, and we found actually very similar results when we did the same exact study looking at the Tdap vaccine. And what this was a study looking at patients in 3 different groups: patients who are on combination therapy with an anti-TNF and an immunomodulator, patients with IBD just on 5 ASAs, so theoretically a healthy IBD group, not immunosuppressed, and healthy controls. This was a study that we used with the 23-valent pneumococcal vaccine, and we looked at 5 of those 23 serotypes in patients after vaccination. And what we found was that the patients in the blue are those that are on combination therapy had significantly blunted immune responses as compared to the patients who were not immunosuppressed. What was reassuring was that the IBD patients who are not immunosuppressed had the same vaccine responses as patients who were the healthy controls without IBD at all. And that blunted response is about 50%. So recognize again that being on combination therapy does blunt that immune response. However, to also make the point, that doesn't mean they shouldn't be vaccinated. You should take the opportunity to still vaccinate these patients with these non-live vaccines that prevent these important respiratory infections. What are the recommendations when it comes to pneumococcal vaccination? We now have 2 available vaccines, and actually for patients who are immunosuppressed, recommendations from the IDSA, the Infectious Disease Society of America, are to use both vaccines to prevent pneumococcal disease in these patients. There's the 23-valent vaccine, which is very broad, but not that strong, and then we have the super booster 13-valent conjugated vaccine, which works really well, but it's more limited in focus. And so by giving patients both vaccines, we're covering them broadly, and we're also giving them the better coverage for those 13 most important and virulent strains of pneumonia. Recommendations are for patients who are naive to vaccinate them once with the PCV13, and then after 8 weeks to be able to vaccinate them with the broader 23-valent vaccine. Some of our patients, though, may have already received the 23-valent vaccine because they might have gotten it as kids if they had asthma, or they may have received it, it's recommended broadly in the general population over the age of 60, and the PCV13 has only been available for a few years. So if a patient's already had the 23-valent vaccine, then the recommendation is to give them a catch-up with the 13-valent vaccine at least 8 weeks after the 23-valent vaccine. And then finally, that 23-valent vaccine does get a booster at 5 years. It's not every 5 years, but 1 booster after 5 years. So patients at age 60 and then a booster again at age 65. With respect to HPV, Gary touched on it, just to again show you a little more data. And this is some data that we learned from Susie Kane, who published this very early on, one of the first people to show us that there was this increased risk of HPV that's associated. HPV we know is associated with cervical and anal cancers. Women with IBD have an increased risk for abnormal pap smears, is what we've learned. And importantly, that risk goes up with immunosuppression. So it's not just IBD, but it's really IBD with immunosuppression seems to increase that risk because cervical cancer is an infectious disease, or it's the result of an infectious disease with HPV. What's interesting is that patients or women with IBD found to have HPV have a higher rate of the more virulent serotypes associated with cervical cancer. That's HPV serotypes 16 and 18, which are targeted in all the vaccines against HPV. The guidelines with respect to the frequency of pap smears that allows some more years to elapse with the revision of the guidelines between pap smears really don't apply to women with IBD who should continue to get pap smears on an annual basis, especially if they're immunocompromised. And there are some data showing us in patients with IBD, but broadly that HPV vaccine, which is a non-live vaccine, is appropriate and safe for all patients, regardless of being immunosuppressed. Gary has listed for us already the live vaccines that are generally contraindicated if patients are immune suppressed. And again, to remind us, the live attenuated influenza virus, that's the flu mist that's inhaled, yellow fever, which endemic in Africa and parts of South America, the BCG vaccine, which is not given in the United States, but is given in parts of the world and in Europe where TB is more endemic, MMR, measles, mumps, rubella, varicella, and zoster, which we'll talk about. And Gary has already mentioned to us the CDC guidelines, which have been around for more than 10 years, that it is safe and appropriate to administer this live vaccine in patients who are on immunosuppression at these doses. So this was one of the pre-test questions, just to emphasize the point that this recommendation has been around, again, for more than 10 years, that we can and should administer this live vaccine for patients who are immunosuppressed with these doses of these medications because of the significant risk of zoster. With respect to general recommendations around live vaccines, question comes up often, how long do you wait to start immune suppression after a live virus vaccine? The IDSA guidelines clarified for us at least 4 weeks, and then some pearls about household contacts that have been touched on already. I want to talk about this study that Millie did. Millie, sorry we keep picking on you, but you've given us all the data. So we know that this risk of zoster is prevalent in patients with IBD, but digging a little deeper in Millie's data is the chart on the left, which is showing us that the zoster risk increases with age. Now we know that zoster risk increases with age in the general population too, and that's why in the general population the recommendation for zoster vaccine is at the age of 60. So everyone over the age of 60 should get a zoster vaccine, zoster vaccination. But if we look at that, and permit me to be a little creative with your data, Millie. What I did was I looked at that data, and looking at that recommendation for the age of 60, which is when the general population is advised based on overall risks and benefits and costs and whatever goes into making health policy around a vaccine recommendation. For patients with IBD, for patients not with IBD, that's when that risk reaches around 700-800 cases per 100,000 people. Now, in patients with IBD, as young as in their 20s, they're approaching that same risk. So I just want to ask the question, with IBD, should we really be thinking about zoster in a different way? Because our patients are hitting the risk of the average person who may get to that point at age 60. Our patients are getting that risk, are having that risk of zoster as young as in their 20s. And so should that have implications as to when we should be thinking about vaccinating our patients broadly, irrespective of any medications, which we're going to talk about now in the next slide. So let's talk about medications and zoster risk associated with IBD therapies. We know that there are increased risk of zoster in IBD in general, and then digging a little deeper into Jim Lewis's paper using the GPRD that was published about 10 years ago, actually 12 years ago now. There's two medications that popped up were corticosteroids and azathioprine, and actually the database didn't really include patients with anti-TNF, so this really predated the biologic era. And at that point in time, we already saw signals from steroids and azathioprine. What we've learned recently and presented at this DDW is an increased risk associated with tofacitinib. And as Millie told us, tofacitinib is now approved for ulcerative colitis, so it's important that we recognize what this risk is and understand how we think about it with respect to our patients. And this timing is everything, right? That's the theme here. So this was just published 5 days ago. And so this is also available, it's published at the IBD Journal, and the data can be found there. So we know that there's been an increased risk that was associated with tofacitinib in the RA trials. And looking at the pooled ulcerative colitis trials, the risk of zoster seen in the tofacitinib trials was about 5%. There were 65 cases out of about 1,150 patients that were in this analysis. What's reassuring about this data is that the vast majority of the cases that were seen in patients in the trials were uncomplicated and were self-limited. But there were some more complicated cases, 11 cases of patients who had multidermatomal involvement, 1 case of encephalitis. The risk seems to be dose dependent, so there were a greater proportion of patients who had zoster who were receiving the higher dose of 10 milligram BID dose as compared to the 5 milligram BID dose, and I think that's an important point as we start to learn about how to use this drug in clinical practice. And so using the lowest effective dose is something that we need to be thinking about. The risk seems to be stable over time, does not go up over time that a patient is on the drug without a cumulative nonlinear risk. And there are particular risk factors for who are the patients that are most likely to or more likely to get zoster, and those are patients, again, with increasing age, which we've learned in parallels that's in the general population, as well as those who are prior anti-TNF failures, and interestingly, in the Asian population, which was also seen in the RA data. So we have 2 zoster vaccines that are available, live and non-live. We have the older vaccine, or the Zostavax, and the recommendations are listed there that have been mentioned. And then we have the newer vaccine, the Shingrix, as Gary mentioned, and that now is something that we have to think about. How are we going to, this is a new vaccine that was just approved within the past year, and so we have to think about how to administer it and in whom to administer it. It's 2 doses, it's given once and then 2 to 6 months later, and is licensed for age 50 and older. So I just want to end in the last minute really to think about what are we going to do from here. So I just attended this great vaccine symposium. I learned a lot about vaccines at DDW, and I want to start improving the quality of care that I deliver when I go back home and I start taking care of my patients again. So let me start with something easy, like reminding all of my IBD patients that they should get a flu shot. So what can we do from a quality improvement standpoint to achieve that? Remind each patient at the time of their visit to get a flu shot, add a reminder to the nursing intake forms, or to add a vaccination checklist. And the answer really is to not make yourself remember, but I want to emphasize that checklists, changing your template, doing something different in your system that will remind you to be able to not miss and not let patients fall through the cracks. There are freely available online checklists like the Cornerstones checklist that's available at the Crohn's and Colitis Foundation website. So thank you very much for your attention. To summarize our ACG clinical guideline recommendations, there are specific vaccines that we need to be thinking about in all of our patients, specifically the respiratory vaccines. There are special considerations for immunosuppressed patients when it comes to pneumococcal vaccination, and when it comes to thinking about the risk of zoster in our patients and how to appropriately vaccinate them as well as a whole host of non-live vaccines, all of which are safe to administer to our patients irrespective of their immunosuppressed status. Thank you very much for your attention.